Okay, so I think we will start now. So welcome to everybody. This is our 13th webinar from the Health Research from Home program. Delighted that you've been able to come along today. My name is Will Dixon. I'm the lead investigator for the Health Research from Home partnership. I'm a consultant rheumatologist and a professor of digital epidemiology, and supported in the webinar today by Coral, who does all of the hard work in the background coordinating things. Today we're going to just do a bit of housekeeping, and then we're really excited to hear from Ed Ramos and Katie Baca Motes about the Progress trial. Really innovative and interesting study that I'm sure you're all going to enjoy. We'll hear from the speakers for 30 minutes, and then we'll have a 10-minute Q&A. And then we're going to have an update about one of our two driver projects that are learning about how we join together patient-generated data to other national data assets. And Nathan will speak about the COVID study, and then we'll finish with a few announcements. But first, the housekeeping, the exciting part. We're recording the webinar, and we will be posting the webinar on the YouTube channel afterwards, just the first 30 minutes where you'll hear the talks. Through the talks, we'd encourage you to enter questions into the Q&A function. You'll be muted through the talk, but we might come to people or unmute you for the Q&A, or we can read those out. And you can use the chat to interact with one another through the course of the talk too. So it's my real pleasure to invite Ed and Katie to speak. They're co-founders of the Scripps Research Digital Trial Center, and I really look forward to the talk. I've had a preview. It's fascinating stuff. So Ed, Katie, over to you.
Fantastic. Thank you, Will and Coral, for the invite. It's been great interacting not only with you for this webinar, but also for a bunch of other health research from home opportunities. So excited to share a lot about what we do on the digital direct-to-participant side of things. I think Katie and I can talk about this particular study for hours and hours, but we really tried to extract what we think were some of the core and critical learnings, as well as areas where we would love to have an opportunity to go back and do again, and try out different applications of this decentralized approach. As Will mentioned, Katie and I founded the Digital Trial Center that sits at Scripps. I oversee the day-to-day operations of the team, and come at this from very much a biomedical background as a population geneticist. Katie has been a partner in crime across a variety of different initiatives, and is a great pairing with her applied behavioral research hat. And so it's been a lot of fun really taking both of our lenses into the clinical research and clinical trial space. But specific to Progress, we've always had an attraction towards tackling a lot of these complex physiological processes, and metabolic health is certainly a poster child for that. As you can see, kind of by this family of impact in terms of physiological downstream effects that fall under the metabolic health umbrella, in terms of really its importance in day-to-day body functions that impact the immune system, the digestive system, endocrine, cardiovascular, and so on. And importantly, certainly with our lens here nationally in the United States, we're talking about numbers that really lay out and paint a significant public health crisis. And that is with over 130 million adult Americans with diabetes or pre-diabetes. You can imagine the cost of healthcare associated with that, well into the hundreds of millions just in a single year alone. And then, of course, the gap is, how do we tackle this significant public health problem with the existing clinical tools that we have, decision-making processes that we have, and predictors that we currently have? And that's really where we turned our eye on for this particular effort. Not not an independent effort by any stretch. There's been a number of different publications that are really trying to get at an understanding of glucose regulation, whether it's impact of genetics, whether it's environmental impacts, really trying to get a sense of what exactly are all the variables that are influencing the changes that we see in glucose response across the spectrum of individuals. And this is really where we got excited about where can we potentially provide some additional input on that regulatory process in the body. And so if you think about anything blood glucose related, you automatically turn to HbA1c from a clinical lens in terms of getting an assessment of where you are physiologically in this particular context. What we were interested in is what exactly does that number mean, and what does it mean with regards to risk? So if you think about the spectrum of normal glycemics to pre-diabetics to potentially progressing to type 2 diabetics, also recognizing that we know clinically that with certain interventions you can regress back to pre-diabetic or potentially stay in a preventative state as a normal glycemic, not progressing to any kind of significant clinical indication. And so we were really interested in trying to tease out what that heterogeneity may look like for a single point in that kind of HbA1c scale. But in order to do that, we recognize as kind of the lead up to this in terms of all of the different variables and factors and influencing characteristics that go into understanding that physiological process, that we need to match that with a collection of data across a variety of different modalities. And so to really kind of streamline and simplify our model, we're looking at collecting data as it relates to demographics, anthropometric values, obviously getting a sense of what those glycemic characteristics are, additional context physiologically, and then the intimate tie between glycemic response with nutrition. So we need an understanding of food intake. And now with the opportunity to explore the gut microbiome, and really pair that also with additional understanding of what the genomic classifiers of risk are, we can really put all those into a pot to drive towards, are you progressing as an individual towards type 2 diabetes or not? And so this was set the stage for our multimodal design, really a deep data capture in the metabolic space towards prediction of glycemic response. And so thus progress was born and really gave us an opportunity to flex not only our research muscles in terms of identifying what those outcomes of interest can be, but importantly, and a big part of this webinar today, are operational muscles. So if we're thinking about all of this different types of data collection, from EHR to self-report to biospecimens and so on, we really needed to meet the challenge for each of these different types. And so we're going to highlight how we step through very methodically and organize this into a completely self-guided, completely remote clinical trial for our participants, but still with an eye on collecting robust data, contextualized data that can drive towards that real world evidence analysis. With regards to the actual trial design, and just some numbers here to give you a sense of what we're talking about. Obviously, recruitment looks a little bit different. This is not in person. This is not in clinic. So we are not relying on a patient population per se, and as well as clinicians and their patient population. This was more leveraging social media, And in the clinic partners that we did have, being able to target specific individuals based on their clinical characteristics. So we typically call this a slice and dice of the electronic health record, where we're able to select certain variables and work with different patient clinics that then outreach out to their individuals with enrollment invite for the study. The social media, even that had a bit of innovation on our end. There are obvious things like Facebook ads and so on, but we also made use of a app called Nextdoor, which is essentially neighborhood localized social media, typically used for things like, hey, can you recommend a plumber or a contractor? But we were able to leverage that locally in the San Diego area for recruitment of individuals towards an interest collection list. And it worked so well that we actually weren't prepared. We were able to build up a list of almost 1,000 interested individuals, and then ultimately be able to leverage them downstream when we're able to get the study off the ground. Given that this is self-guided, it is very much a digital infrastructure. So we build out the study app, and this really is a self-contained ecosystem in terms of guiding the participant through all of the different tasks and different features of the study. This includes ordering different types of kits, and we'll kind of step through what that self-administration of biospecimen collection look like, as well as the active data collection through things like continuous glucose monitor. And then, of course, I would almost put at the top of the list a high priority on what that data return look like, what the participants do to share their information with us, and then what we do to share that information back to the participant in terms of health insights. By the numbers at the bottom here, at the top of the funnel, we had over 1,100 individuals enrolled and consented into the study. We were very proud to almost have about half of them be considered and characterized in UBR, or underrepresented in biomedical research. This is not just through race and ethnicity, but also socioeconomic status, education status, and so on. So an important pillar for us in the structure and design of all of our studies is ensuring appropriate representation. And then when you're talking about type 2 diabetes in the United States, it's extremely important to recognize the demographics associated with the prevalence of that disease. There was a requirement for participants to connect their EHRs. So the electronic health record in the US, we do not have a national system as is available in the UK. But we do have an increasing set of tools that allow for some level of interoperability across systems. Our platform allowed for participants to essentially navigate to their patient portal and then select and authorize the types of health record data that they wanted to share with the study. I would say importantly, just to highlight here, that allows for setting the stage for a bit of trust and transparency as well, where participants are not only identifying the type of information that they want to share, but within the app, once that connection is established, and it's very quick, it's a 1-minute process of tapping and authorizing, they're able to see excuse me, their data within the app. So it really turns into a what you see is what you get kind of situation, in which the study team and the types of data that we're accessing is extremely transparent in terms of the participant being able to see what they're sharing within the app as well. And it actually can serve as a bit of initial information and data return, so to speak, in that folks may not be consistent users of their patient portal, and so they can actually see what's in there in terms of their medications, their treatments, and their clinical history and so on. So obviously that we can see a drop off there just because, again, we don't have a nationalized system. And so the actual process of connecting individuals to their patient portal is around 80 to 85% of health systems in the US. And so we were expecting a drop off at that particular threshold. But excited to see the continued interest by participants, even if when we ask them to order a bio kit and collect their own biosamples, and then order a glucose kit and monitor their own continuous glucose monitor as well as their food intake. And so we'll step into specifics here, and I'll hand this over to Katie. And Katie, just let me know when you're ready to advance, and I'll happy to click through.
Hey, hi guys. Thanks, Ed. Yeah, now is the fun part. So as you could see from Ed's diagram, this is a pretty complex study. We're asking a lot of participants. And we really had to think through how are we going to motivate people, especially in those early stages of this study, to complete everything that we were asking them to complete, from all of their surveys to that EHR connectivity that Ed mentioned, to filling out, doing their bio kits, doing their glucose kits. So this was fun for us. As Ed mentioned early on, I have a behavioral science background that I don't get to use very often. But in this particular study, I got to bring that back. I used to work at places like Disney Research. And so it was fun to work with the team. And we really started to think about, okay, how do we build out these incentives? Do we need to use some sort of gamification? What reminders did we need? So we all went through this study as a dry run and started to notate which things were difficult, where did we have reminders, what are tips and tricks that we kind of developed on our own that we can then give over to the participants. So it was pretty complex. I will note that we keep saying it was completely self-guided. That's not how we designed it in the first place. We actually thought, even though we specialize in digital trials and we have a lot of experience with this, we thought for some of these things, people would want a study coordinator. Let's get them on the phone. Let's get on Zoom. Let's walk through this process. Would people want to put on a CGM themselves, draw their blood, figure out their stool sample? We really thought that you needed to have a human in the loop. But at the same time, in the spirit of, kind of pushing the envelope, we decided to build a completely self-guided pathway where people got videos of how to do these things. And then we early on gave people the choice. Would you want to set up a call, a Zoom teleconference with a study coordinator to walk you through these processes? Or would you like to watch the videos on your own? Nobody picked the study coordinator calls. So it was like, blew us away. It was, one of those A/B tests where you knew at the very, very early stages that, which one was the winner. So that was really interesting to us. And then that enabled us to have a completely self-guided. Now, self-guided does not mean low touch. It was very, very high touch, very personalized. As you can see from some of these screenshots, we had a threshold-based point system. So every time they completed an activity, they were getting points. They could see the progress towards their next gift card, which was a financial gift card, Amazon.com. And they were able to build up to all of those at certain thresholds. So there was a lot of thinking around, do the points match the activity? Do we have the gift card right after kind of a big ask and a big hump? So lots of thought was put into that, and people were able to go through and earn these financial incentives and have a little bit of gamification on the way. And if you go to the next slide, Ed, we also had, it wasn't just financial incentives. It was also things like personalized reminders. Oh, you forgot to charge your Fitbit, or, oh, did you remember to fast? Or here's an easy tip and tricks to keep all of your data in one place and to remember when to do these things? Did you look at your application? So lots of activity and lots of personalization within the study app to guide them through that entire experience. So we'll talk about it a little bit later. Ed's going to go over it in the webinar. We also have that return of data and return of information that they saw in the app. All of this combined, Ed, if you go to the next slide, all of this combined, we think led to the relatively high engagement rates that we have. As you saw in the funnel, we had that big dip at the front of people who couldn't connect their electronic health records. But after they got through that stage, we had what we thought of as really high engagement rates through the rest of the thing, considering all of the things that we were asking them to do, tracking their food, doing biosamples, connecting their CGM. We had a lot of people who were very excited about this. And even so much so that they were asking for another CGM at the end of their active data time, where they wanted to keep going and collect data for their own purposes as well as for the study. So I think the main takeaways here are that digital design, even though it's not a lot of human in the loop, it allows for a really personalized high-touch experience, which is something that's a little counterintuitive to, I think, kind of the general thinking of these digital study designs that we all do. What would we have done differently? We talked a little bit about A/B testing. Obviously, we would have A/B tested everything. We kind of threw everything at this, but we don't really know what works. Was it the $175? Was it the gamification? Was it the reminders? Was it that they were getting information back every step of the way? And all of those things cost money. They cost time and money, and we don't know exactly what worked to really motivate people to complete the things. So ideally, in an ideal world, we would have had plenty of time and resources to truly get to the bottom of what was working and what wasn't. So the next step, this was the biggest kind of unknown for us. We had done a lot of digital studies before. We kind of had a general sense of, do people know how to put on a Fitbit? Will they connect their electronic health records? Will we get a decent response back on the validated surveys? But some of this stuff with the remote biosample was new to us. So if you go to the next page, we had some experience prior collecting saliva, but blood in the home was new for us, as well as stool sample in the home. So we were like, oh, I don't know. Again, we all did a dry run at the beginning of the thing. Some of us got through everything. I was not one of those people who got through everything. I remember my young son coming in, and I was doing the blood draw, and it kind of got wonky and blood was getting everywhere. And he's like, Mom, people are going to sue you. What's going on? So it was kind of a crazy experience for us to try and do this. And so it was exciting to kind of test different methods, test different vendors, try and put all this together, have everybody do the dry run. We learned a lot in that process, things that you may not think about. Finger strength, for example. Do our older patient population have the finger strength to do the touch-activated phlebotomy device by themselves? Are we thinking about ways that we can say, okay, when you're doing your saliva sample, for example, think about something sour like a lemon, so that you can get enough spit in your saliva sample. So we didn't just rely on the packaging that came from the individual vendors. We actually created a bio kit with all of those learnings, and we had step-by-step instructions as well as videos in the app on how to collect all of these biosamples. So next screen, we had, what we thought was way higher return rates than what we had anticipated. So of the 699 who consented and connected their EHR, 664 ordered a bio kit. So they got to the point where they got it sent to their home, they got to open it up. And these numbers here show you 76% of participants collected their saliva samples, 76% blood, and then 71 on the stool sample. So pretty high across the board. And I will note that these are samples that were sufficient for being included in the data set for the analysis. So not only did they ship them back, but samples were good. They got through the lab, they were analyzed and good to go. So the stool sample was the one we had the lowest response rate on, and we're continuing to iterate with our vendors on that. We actually had a change in the middle of the study to make it a simpler collection process, and hopefully that helped. I don't know if we have pre and post on that, but anecdotally, people preferred the second method of collection, which is just a wipe. So it's fun to start to innovate on those aspects of things as well. Next slide. So what would we have done differently? Again, we probably would have just gone with the self-guided from the beginning. We didn't know, we didn't have to build out the telehealth kind of visits and all of the work that went into that. And then really just make sure we're reconsidering incentives and motivations, and we'd love to get it closer to 100% sample return on all of the folks that were doing that. So I think there's some more incentives and motivation that we can do through that entire process. So lots of learning on this particular area. And Ed, I will turn it back over to you for this part.
Fantastic. Yeah. So in the last few minutes here, we kind of take it home with some additional data collection, as well as what that data return looked like for participants. So as Katie mentioned, stepping through the biosample, the next big data collection front for us was the wearing of the continuous glucose monitor, wearing of the study provisioned Fitbit that allowed for that collection of digital measures like resting heart rate, sleep, physical activity, and then also leveraging a food diary additional app. And so while everything was self-contained within the study app, because of the different devices and sensors, and in some cases, specific to the nutrition collection, we had to guide the participant outside of the app. So there was even logistics within the app and really trying to control that data collection. And so it was great to have the participants be able to follow all of that. But you can see a snapshot here when they receive, in this particular case, the glucose kit, as Katie was mentioning, a bit more customization and personalization to really orient the participant to all the different things, because this was complicated. We're asking them to do a lot of things. We're asking them to use different apps, and there's a lot of different instructions for each of those. So for the food collection, which now you could probably spin up using ChatGPT or your favorite LLM, but back then, BiteSnap was one of the first apps kind of leveraging a picture-based capture of your meal and then extracting macronutritional information for that we use in the analysis. About 90% of the participants shared their Fitbit data. 87% of participants shared that log food through BiteSnap, and about 73 participants had sufficient use of the Dexcom G6 continuous glucose monitor, and that's out of a total of 514 participants. We called this the active data collection. There was a ton of participant reported outcomes via surveys, demographic information early on. But outside of the biosample collection, this was really where the participants were putting in the work for about 10 days, really tracking a lot of all of these individual data and insights. For a subset of individuals that chose to do so, we made this optional just because of the sugar bolus that we provided in the fasting component of this. But even then, we made sure to have customized instructions that really kind of allowed for the participant to step through different aspects of the fasting process, which was ensuring that you stop eating, drinking at a certain time, and that you have the sugar bolus, which was actually 2 bars of a Nutri-Grain in the morning. But it was helpful analysis and data collection on our part, even in an optional setting. In terms of what we would have had differently, we really, I think, recognize that customization making a difference. Even something as simple as a saliva package As Katie mentioned, you get this 20-time folded package insert. And so if you're relying on that for the participant to truly understand what to do, I think you're going to have a lot of drop off in that particular case. The food journaling was not ideal. That I think remains a challenge in this space of how to appropriately, with a low burden, capture a person's day-to-day or intraday meal intake. But I do think there are opportunities to do that differently. So for example, if those of you who explored any of the functionality in the Aura Ring, their platform doesn't necessarily focus on macronutritional breakdown, but rather just the type of meal that you're collecting. And so that may be suitable for your analysis and a little bit simpler in terms of not having to necessarily worry that it got 1 cup of peas instead of 2 cups of peas, or a cup of rice, and so on. And then the fasting, as I mentioned, really allowed for a setting of a baseline. And this is more of a done differently in terms of the downstream analysis and analytics. It would have been, I think, it would have allowed for a more robust analysis on our end if we had a larger subsample that did the fasting component. And we were able to show that it was possible and without necessarily issues. So in the last few minutes here, just want to bring it home with what we think was one of the more exciting aspects of the study, because it really tied everything together. So we're trying to get an understanding of what are the variables that can potentially influence glycemic response. And are they different across normal glycemics, pre-diabetics, and individuals diagnosed with type 2 diabetes? That's what we're doing on the back end with all the data that we're collecting from participants. But we wanted to make sure that they have some level of motivation based on the understanding of the study. And so we developed this very simple data visualization, but ended up being very impactful and very powerful. And that is pulling the real-time data that was coming off the Dexcom G6, overlaying that with the macronutritional information that's being pulled from the BiteSnap, so that at an individual level, a participant can look and see, oh, meal 1, which may have been my bagel or a stack of pancakes in the morning, spiked my glucose. But when I exercised immediately after, it was able to bring it down. Or why is it that this stayed at a high spike for a certain amount of time for this particular food versus another? And so immediately they understood the purpose and the vision of this study, which is different things can have different impacts on your glycemic response, whether you have normal sugar, whether you're a pre-diabetic, or whether you have type 2 diabetes. And one of the primary feedback that we got from participants was asking for another CGM so that they can continue to experiment on themselves. So that was a huge boon for our study team to not only show that we were able to kind of pull off the operational aspects of this, but also, most importantly, really drive home the importance of the scientific research. And so I think as a result of that, we really would focus a bit more on that real-time data capture and how to drive more personalized health insights. And to Katie's point, in terms of A/B testing, it would be extremely interesting to see, could we actually bring that monetary value down, but substitute that with more personalized health information, and with that allow for continued retention and motivation and incentive for the participant in the study. And so there are things like now changing it, not just individualized, but how they compare to the larger cohort or to specific demographics that are associated with the participants. So there's a lot that we could continue to do in this kind of personalized health insights space. And so ultimately, this led to a publication in Nature Medicine. And as I alluded to at the beginning of the webinar, we were able to show that at a given HbA1c value for a pre-diabetic, that all of those other different types of data that we were able to put in our binary classifier was able to show a difference in risk towards type 2 diabetes or potentially even regressing to normal glycemia. And so in terms of a clinical impact and the translation of this, being able to say that, oh, let's just rely on HbA1c is not the complete story and not the complete picture. And so we have an opportunity to really start the conversation in the clinical community to think, how do we approach not only diagnosis, but treatment and prevention differently? And so with that, Katie, if you want to just bring us home in the last 30 seconds here, and then we can take some questions.
Yeah, so this just shows you this is one of our many platforms over at Scripps in many of our areas of interest. We have a lot going on in the pregnancy space, in the cognitive space, in the metabolic health space, and have done a lot with nationwide consortiums, including Detect for COVID and the All of Us research program. And Ed and I can talk about these things for hours. So next slide. If anybody's interested in continuing the conversation beyond the time we have today, please do look us up. We both have our time over at Scripps. We also spun out a new company called GSD Health Research, which allows us to work more broadly across the ecosystem. So we wear a couple of hats now, and GSD Health Research, in addition to decentralization, digital health technology, we have a real focus on women's health. So if anybody's doing cool stuff in the hormone data layers, cycle data, and combining with other multimodal data collection, we'd love to continue the conversation.
Nathan's going to tell us about progress in one of the two driver projects that are learning how we join together patient-generated data to NHS data. So over to you, Nathan.
Thanks, Will. Yeah, hi everyone. I'm going to give an update on our the second driver project, which is looking at the consequences of long COVID on people's long-term health outcomes. I've spoken a few times before, but just to recap for anyone that's not familiar, this is a study where we have a cohort that were recruited from during the COVID-19 pandemic, where we have patient-reported data through a smartphone app where people were logging on the day their symptoms that they were experiencing, as well as COVID tests and vaccines. We then recruited from that app into a biobank where we took additional samples, blood samples, stool, as well as collecting additional data through retrospective surveys over the last 5 or so years, coming up to 4.5 years. And the plan is to link our study data with electronic healthcare records for our participants in the UK. And that's using the UK longitudinal linkage collaboration platform, which is a kind of a medium through which we can access and analyze the NHS data, with the overall goal to try to understand the long-term impacts on health for people who are living or had experienced long COVID, and many of whom are still experiencing symptoms today. So this linkage process is has been quite lengthy. I think we're around 18 months or so in, and we are up to the point where we are going through the legal process of agreeing contracts to be able to transfer our data to the UK longitudinal linkage collaboration, and hopefully within the next few months we'll get to the point where we are able to start analysing it. So just kind of summary of the progress we've made. We actually had to renew our own study ethics, because we've been running for 5 years, and we've had to update our participants about the data linkage process, and give them a chance to opt out in case they changed their feeling about their consent to link with healthcare records. And so that's ongoing, and it's due to finish in the next few weeks. At that point, we'll be hopefully ready to transfer our data and have our data transfer agreement signed, which is currently with our contracts team who are agreeing that. And then we'll be preparing the data. So the first step will be to share identifiable information for the purposes of matching to the right record within the NHS. So things we've collected people's NHS numbers, and then that's used alongside basic demographics to try and get the correct match within people's hospital and GP records, in a way that's done in a very safe and controlled way. And we're working towards a deadline of the start of May to do that, with the hope that in the cycle that the UK longitudinal linkage collaboration work in, we should hopefully get linked data in the summertime, at which point we'll be ready to analyse. But in order to do that, we have to do an extra process, which is to actually apply to use our own data, which is a process that everyone who wants to use this platform has to go through, where we describe the study, the analysis plan, and it gets reviewed and approved as a way to safeguard the data and make sure that it's used in the appropriate way, safely and appropriately. And so we're also going through this process concurrently, with the hope that we'll be ready to analyse in the summertime, from the summertime onwards. And that's it for me. That's where we're up to now. So hopefully some progress in the next few months.
Wonderful. Thank you, Nathan. I mean, it's interesting, isn't it, that one of the arguments for using data that already exists is that it will be quicker and easier than collecting data that you collect prospectively. But the reality is that at present, those pathways aren't very well trodden. And so things do take a bit longer than we might otherwise expect. But we're going through the pain ourselves so that other people can do it more smoothly in the future, just like Ed and Katie are learning how to run these sort of decentralized trials. So thanks, Nathan. I'm just going to finish by sharing a few adverts. So the news is that we've got more events coming up. The next Health Research from Home in-person event is our hackathon. That's running the 13th to the 15th of May. We have about 20 slots available for people to join this 3-day event, and we'll be getting hands-on, active with data and trying to understand how missing data impacts upon analysis. So you can follow that QR code and sign up if you're interested. The subsequent face-to-face event is a grant writing retreat. So you may be listening to these webinars, coming up with brilliant ideas in your own disease area, but the next step is you've got to write the grant and get it funded. And this 2-day grant writing retreat is to support you in doing that as well as possible, with advice from experts who've done it themselves, from information governance backgrounds, patient and public involvement and engagement, how you describe the technology, how you pitch the whole thing together. So again, follow the QR code or go to our Health Research from Home website and you can register your interest now. That I think the dates are likely to be early July, but we'll be publicising the final dates a bit close to the time. The Paprika study, which is the sister project to what Nathan showed, led from Manchester. We're trying to learn how you can join together patient data and link to national data assets, this time in knee replacement. We are open to recruitment. We're looking to find people who've already had a knee replacement between 2017 and 2023. So if you know somebody who's had a knee replacement and carried a device or wore a device during that time, even just an iPhone, that will have been tracking their steps. They can sign up, donate their step count data, and contribute to answering this question of how much better physical activity gets after knee replacement. So please do encourage people to take part. That would be great. All of these webinars are available on the YouTube channel for the first 30 minutes of the presentation. So you can go and find past presentations there. And in fact, our annual event that ran last month, all of the presentations were recorded from that, and they are also available on the YouTube channel. Here's the final set of resources that you can scan to take you to the study website, our LinkedIn page, or our GitHub, where there are lots more resources. So thank you very much for coming along. A special thanks to the two speakers, Ed and Katie, as well as to Nathan. Hope you join us again next time. In 2 months, the next webinar is going to be presented by Rajiv Kumar from Apple. The Apple rules mean that we can't record the webinar. So if you want to hear, you need to come along and listen live. So thanks very much. Sign up for that one now, and we'll hopefully see you again in 2 months. Thank you.